Welcome to Bookfulness.
Hello!
You've tuned into our deep dive, episode 30. Quite a milestone, actually.
It really is 30 deep dives already.
And today we're wrapping up our really intensive look at the lower limbs anatomy.
It's been quite the journey. Last time, if you remember, we navigated the really complex territories of the thigh and the leg.
Yeah, all those compartments.
Exactly. The extensor, flexor, lateral compartments, digging into that muscle bulk and the intricate nerve pathways powering everything.
We certainly mapped those powerful proximal segments. But today, well, our focus shifts completely. We're heading down to the distal powerhouse.
The foot.
The foot, yeah. The highly specialized, incredibly intricate structure that takes all that upstream force and translates it into motion. We're talking about the foot and its joints.
It's where the rubber meets the road, quite literally.
Precisely. We're drawing primarily from the original book, pages 1202 through 1225, for the muscles and neurovasculature, and then we'll jump ahead a bit to pages 1254 through 1266 for the joints and arches.
When you think about it from a biomechanics perspective or even evolution, the foot is it's an astonishing piece of engineering.
Below the knee. Yeah.
Absolutely. It's not just a passive platform. It's this flexible, adaptable bridge. It has to manage two completely conflicting jobs, right?
Rigidity and flexibility.
Exactly. Total rigidity for standing still, providing support, but then dynamic flexibility for absorbing shock and propelling us forward. If you want to understand movement, you have to understand the foot.
Okay, let's start laying that foundation then. The foot takes enormous load, day in, day out. So its soft tissue support, the fascia, must be incredibly tough. Starting around original page 1202, what's the basic structure we see in the sole?
Well, the complexity hits you right away on the plantar surface. If you were to section the sole, you'd see it's not just one big block of tissue.
No.
There are these things called intermuscular septa. They extend deep from the edges of this thick central band, reaching towards the first and fifth metatarsals. And what they do is create these distinct fascial rooms.
Compartment.
Exactly. 3 primary fascial compartments. That's really a key organizing principle for understanding the sole of the foot.
3 compartments. That sounds familiar from the leg, but maybe serving a slightly different role here. More about containment.
Yeah, largely about containment and function. We define them by what they house, what they protect. So if you look at the inside edge, the medial side, you've got the medial compartment.
Okay.
It's covered by a relatively thinner medial plantar fascia, and this compartment is basically home base for the muscles working the great toe.
The hallux muscles.
Right, the abductor hallucis, the flexor hallucis brevis, that really important tendon of the flexor hallucis longus running through, plus the medial plantar nerve and vessels, all packed in there.
So dedicated space for the big toe's mechanics and stability. What about the other side, the lateral compartment?
The lateral compartment kind of mirrors the medial side, but for the little toe. It contains the abductor digiti minimi and its related nerves and vessels, balances things out.
And sandwiched between them.
That's the big one, the expansive central compartment. This is, the main engine room of the sole. And it's protected by a structure that really deserves its own focus. The incredibly dense plantar aponeurosis.
Ah, yes, the plantar aponeurosis.
Yeah.
Often gets mentioned with plantar fasciitis, but structurally, it's critical. It's not just a lid, is it? It's doing work.
It's doing major work. It's more than just a cover. It's a passive tensile structure. It's this really tough, specialized layer of deep fascia.
So how does it handle the massive forces, running, jumping?
Yeah.
The compression must be huge.
Well, its role is really twofold. First, mechanically speaking, it acts like a tie rod or a spring.
Okay.
It passively helps maintain the longitudinal arch, spanning from the heel to the toes. But second, and this is maybe more important clinically, it works together with this highly organized layer of fat globules, all tightly bound. Together, they form this protective shield.
A shield against compression.
Exactly. It stops the crucial vessels and nerves within that central compartment, things like the long flexor tendons, the deep plantar arteries from being squashed flat during peak weight bearing. Imagine the pressure.
It's like built-in padding and a support beam all in one. And if that aponeurosis gets inflamed, like in plantar fasciitis,
then your ability to manage load, to absorb shock, to push off, it's immediately compromised. It hurts because that crucial protective and supportive layer isn't functioning right.
Makes sense. And what machinery resides within that central compartment under the aponeurosis?
That's where you find muscles like the flexor digitorum brevis, the quadratus plantae, and the lumbricals. This is the core machinery for flexing the toes and providing dynamic arch support. The fascia's job is to let that machinery work without getting crushed.
Okay. Now, before we dive layer by layer into those muscles, let's just touch on that comparison made on original page 1266. The foot has intrinsic muscles, just like the hand, but functionally they're quite different. What's the main difference in their job description?
Yeah, that's a fundamental point. It really comes down to stability versus dexterity. Think about your hand muscles. The palmar muscles, they're all about fine motor control, right? Grasping, manipulating objects, moving fingers individually.
Precision work.
Precision, exactly. Now, the foot also has intrinsic muscles arranged in 4 distinct layers, similar layout, but they generally act as a team, as a single unit. Their primary job, overwhelmingly, isn't fine dexterity like the hand.
Stability.
Stability. Their main goal is to collectively maintain the integrity of the longitudinal arch, or to maybe press a specific part of the foot, like the big toe or the outer edge, more firmly onto the ground for balance, especially during walking or running.
So group effort for a solid foundation.
Okay.
Let's explore how those 4 layers pull that off. Layer 1. This is the most superficial layer, right under the aponeurosis. It seems to act as the boundary layer, providing bulk. Described around original page 1205 and table 7.14.I, 3 muscles forming a sort of tripod base.
That's a good way to think about it. Starting medially, on the big toe side, we have the abductor hallucis. This muscle needs a really solid anchor point,
Why is that?
because its main job is to stabilize that medial border of the foot to resist excessive pronation or flattening of the arch. So it originates really firmly from the medial tubercle of the calcaneus, the heel bone, and also from the flexor retinaculum and the plantar aponeurosis itself.
Strong origin. And where does it go?
It travels forward distally to attach to the medial side of the base of the proximal phalanx, the first bone of the big toe.
And its action reflects that stabilizing role.
Primarily, yes. It abducts, moves away from the foot's midline and flexes the great toe, the hallux, at its joints. Functionally, think about pushing off the ground. This muscle contracts to keep that big toe aligned, preventing it from splaying out too much. It helps maintain a rigid lever for propulsion.
Makes sense. Okay, moving centrally in this first layer, we find the flexor digitorum brevis, FDB. Now, this one's often confused with its longer cousin coming down from the legs, right?
Very common confusion, but the FDB is purely intrinsic. It starts and ends within the foot. It originates right alongside the abductor hallucis from that same medial tubercle of the calcaneus and the aponeurosis.
And its structure is interesting.
Yeah, it's quite neat. It runs forward to the 4 smaller toes, the lateral 4 digits. And just like the flexor digitorum superficialis does in the forearm for the fingers, the FDB tendon splits, it bifurcates, allowing the deeper flexor digitorum longus tendon to pass through.
Oh.
Then the FDB attaches to both sides of the middle phalanges of those 4 toes. Its main action is straightforward. Flexion of those lateral 4 digits at their joints. It gives you that quick, short burst of toe curling power.
Got it. And completing the tripod on the lateral edge.
That's the abductor digiti minimi. This one is really important for stabilizing the outer border of the foot. What's notable is its origin. It actually arises from both the medial and the lateral tubercles of the calcaneus, plus the aponeurosis, a broader base.
Wider anchor.
Yeah. It then attaches to the lateral side of the base of the proximal phalanx of the 5th digit, the little toe. Its job is to abduct and flex the little toe. If you lose stability in this lateral column, the whole foot structure can become compromised during gait.
Okay, layer 1 establishes the boundaries and provides some primary movement. Now, going deeper to layer 2, this seems to be where extrinsic power meets intrinsic control. We have those long flexor tendons passing through, and 2 rather clever intrinsic muscles acting as helpers, also in table 7.14.I.
Absolutely. Layer 2 is fascinating. We have to start with the quadratus plantae. Sometimes it's called the accessory flexor, which gives you a clue.
Accessory flexor, so it helps the main flexor.
It does, but in a very specific way. See, the tendon of the main extrinsic muscle, the flexor digitorum longus, FDL, which comes down from the leg, it approaches the toes from the medial side at an angle.
Right.
If the FDL pulled on its own, that oblique angle would actually tend to pull the toes medially inwards as they flexed, not straight down towards the ground.
Ah, so the quadratus plantae corrects that pull.
Precisely. It's a brilliant bit of biomechanical correction. It originates from both the medial surface and the lateral margin of the calcaneus, and it inserts onto the posterolateral aspect of the FDL tendon itself.
Attaches right onto the other tendon.
Yes. And by doing so, it pulls directly backwards on the FDL tendon. It literally straightens out the line of pull. This ensures that when the FDL contracts, the lateral 4 digits flex straight down, effectively gripping the ground instead of being pulled sideways. Without quadratus plantae, our toe flexion would be much less efficient.
That's incredibly clever design. Okay, and the other residents of layer 2 are the lumbricals. These sound familiar from the hand, too.
They are analogous, yes. There are 4 lumbricals in the foot, just like in the hand, and they have a similarly unique origin. They arise directly from the tendons of the flexor digitorum longus.
Originating from another tendon again.
Yeah. They then travel forward and attach to the medial side of the extensor expansions, those hoods of connective tissue over the tops of the toes of the lateral 4 digits.
And their action is complex.
Highly sophisticated. They perform this kind of coordinated movement. They flex the toes at the metatarsophalangeal MTP joint at the base of the toe, while simultaneously extending the middle and distal interphalangeal IP joints, the joints further down the toe.
Flex at the base, extend at the tips. Why?
Think about gripping the ground. This action allows your toes to press down firmly at the base, maintaining contact, but without curling up completely into a ball. It helps keep the toe pads flat against the ground. It's also thought to help prevent conditions like hammer toes, where muscle imbalances cause the toes to curl abnormally.
Wow. Okay, deeper layer 3. According to table 7.1.2, this layer houses more short flexors and some key muscles for the arches, closer to the bones.
Right. The main player for the great toe in this layer is the flexor hallucis brevis, FHB. This is a strong muscle. It originates from the plantar surfaces of the cuboid and lateral cuneiform bones. Those are tarsal bones in the midfoot. It then travels forward, and interestingly, it splits to attach to both sides of the base of the proximal phalanx of the first digit, the big toe, often enclosing small sesamoid bones within its tendons.
And its action. Powerful flexion.
Powerful flexion, yes, specifically of the MTP joint of the great toe. This muscle provides a huge amount of the force needed for the push-off phase of walking or running.
Crucial for propulsion. Now, we also find the adductor hallucis in this layer. Its name suggests it just pulls the big toe inwards towards the other toes, but you mentioned earlier its role is more structural.
It absolutely is. The name is a bit misleading in terms of its primary functional importance in the foot. Yes, it can adduct the first digit, but its constant, more critical role, especially for its 2 heads, the oblique and transverse heads, is stabilizing the foot's architecture.
How does it do that?
By pulling the metatarsal bones medially, particularly the oblique head, which originates way back from the bases of metatarsals 2, 3, and 4. This action provides significant support for the transverse arch of the foot, the arch running side to side.
Counteracting the splaying forces.
Precisely. It prevents the midfoot from spreading out and flattening under load. If you're treating foot problems, you have to think of the adductor hallucis not just as a toe mover, but as a key stabilizer of that transverse arch. Ignoring that is a mistake.
Good point. And rounding out layer 3 is a smaller muscle for the little toe.
Yes, the flexor digiti minimi brevis. It's the short flexor for the little toe. It originates from the base of the 5th metatarsal bone, and its job is to flex the proximal MTP joint of the 5th digit. Simple, but it contributes to the stability and function of that lateral column.
Okay, 1 layer to go, layer 4, the deepest one. This contains the interosseous muscles, and this brings us back to that key difference between foot and hand function.
Exactly. Layer 4 is right against the metatarsal bones. It consists entirely of the interosseous muscles. Just like in the hand, we have plantar and dorsal interossae.
PE and DAB.
The mnemonic still works. There are 3 plantar interossae, and their job is adduction, PAD. They pull digits 3, 4, and 5 towards the foot's central axis. And there are 4 dorsal interossae, and their job is abduction, DAB. They pull digits 2, 3, and 4 away from the central axis. They also assist in flexing the MTP joints.
But the crucial concept here, mentioned on original page 1266, is which axis they move relative to.
This is absolutely key. In the hand, everything pivots around the middle finger, the 3rd digit. That reflects the hand's need to spread the fingers wide for grasping.
But not in the foot.
Not in the foot. In the foot, all movements of abduction and adduction produced by the interossae are organized around the 2nd digit as the central fixed axis.
Why the second toe?
Because the foot's job is stability and rigid propulsion. The second toe, being typically the longest and most rigidly aligned within the tarsometatarsal structure, provides the most stable, non-moving reference line. Small adjustments by the interossae, pivoting around the stable second toe, allow for fine-tuning balance during walking and standing, without compromising the overall rigidity needed for weight bearing. The hand needs a mobile axis. The foot needs a stable one.
Okay, that's the intricate muscular scaffolding. Let's switch gears now and look at the plumbing and wiring, the nerves and blood vessels supplying this complex area. covered between original pages 1212 and 1217. Let's map out the sensory territories first. You mentioned they blend dermatomes and peripheral nerve fields.
They do. It's quite elegant, actually. When we look at the sensation on the sole of the foot, the plantar surface, it's overwhelmingly dominated by the two terminal branches of the tibial nerve,
Which are?
the medial plantar nerve and the lateral plantar nerve. This split happens back near the ankle, and the territories they cover are remarkably precise.
And for someone assessing nerve function, knowing that dividing line is vital, where is it?
The source clearly states the demarcation line runs longitudinally down the foot, basically bisecting the fourth toe, right down its middle.
Straight down the fourth toe, okay.
Everything medial to that line, the inner side, is supplied by the medial plantar nerve.
And that nerve covers?
The medial plantar nerve, which originates from spinal roots L4 and L5, handles the skin sensation for the entire medial half of the sole, plus the plantar surface, the sides, and even the nail beds of the medial 3.5 toes.
So, big toe, second, third, and the inner half of the fourth.
Exactly. Think of it as the foot's equivalent of the median nerve in the hand. It covers the primary sensory real estate we use for feeling the ground, for fine textural awareness.
And the lateral side then must be the lateral plantar nerve.
Correct. The lateral plantar nerve, coming from roots S1, S2, and S3, takes care of the skin on the lateral half of the sole, plus the plantar aspect, sides, and nail beds of the lateral 1.5 toes.
Little toe and the outer half of the fourth.
Right. It's functionally analogous to the ulnar nerve in the hand. Understanding this specific 3.5, 1.5 split is crucial clinically. If someone has numbness, is it following this pattern, suggesting a plantar nerve issue, or does it follow a different pattern, maybe pointing towards a spinal root problem, a dermatome issue?
Very useful distinction. What about the parts not covered by the plantar nerves? The heel and the top of the foot, the dorsum.
Good question. The thick skin over the heel pad gets its own supply, mainly from calcaneal branches that arise directly from the tibial nerve before it splits, and also from the sural nerve. This is typically S1, S2 territory.
Okay, on the top.
Moving to the dorsum, the vast majority of the skin there is supplied by the superficial fibular nerve, also known as the superficial peroneal nerve. This covers the area from L4 down to S1, but there's one very specific, very important exception.
The classic anatomy exam question spot. The little patch of skin between the big toe and the second toe.
That's the one. That small, but functionally significant web space is innervated by the deep fibular nerve, or deep peroneal nerve, specifically its L5 component.
And why is that patch so important clinically?
Because the deep fibular nerve's main job is motor innervation. It supplies all the muscles that dorsiflex the foot and extend the toes. Having this small, easily testable cutaneous branch allows a clinician to quickly check the integrity of the entire deep fibular nerve. If someone loses sensation just in that web space, it's a major red flag for potential deep fibular nerve damage, maybe from compartment syndrome or direct injury.
A tiny window into a major nerve's function.
Yeah.
Okay, turning to the blood supply. Arteries. We need a robust supply here, given the metabolic demands. Two main inputs, you said. One on top, one underneath.
Exactly. The foot needs a lot of blood, especially during activity. On the dorsum, the main artery is the dorsalis pedis artery. This is actually a direct continuation of the anterior tibial artery from the leg.
And it's the one we feel for a pulse.
Yes, it's clinically vital. You can usually palpate the dorsalis pedis pulse just lateral to the tendon of the extensor hallucis longus muscle on the highest part of the foot's arch. Checking this pulse is a standard way to assess peripheral circulation down to the foot.
Okay. And underneath? On the sole.
The sole gets its supply from the medial and lateral plantar arteries. These are the terminal branches of the posterior tibial artery, which runs down the back of the leg and behind the medial malleolus.
So, different sources for the top and bottom. How do these systems connect? Is there redundancy?
There is, and it's crucial. The connection point forms the deep plantar arch.
An arch of arteries. How's that formed?
It's a really important anastomosis, a connection. The lateral plantar artery, which is usually the larger of the two plantar arteries, sweeps across the sole of the foot, deep in layer 4 near the metatarsal bases. It then joins up with the deep plantar branch of the dorsalis pedis artery, which dives down from the top of the foot.
So the anterior and posterior systems meet deep in the sole.
Exactly. This deep plantar arch creates this high-pressure interconnected loop that sends branches off to supply the toes and the midfoot structures. It ensures that even if one of the main feeding arteries, anterior or posterior tibial, gets partially blocked, there's still usually enough collateral flow through this arch to keep the tissues alive.
That redundancy is key, especially given how vulnerable the foot can be to injury. Okay, Briefly, let's cover the drainage, veins and lymphatics, referenced around original page 1218.
The venous system in the lower limb has two main parts. You've got superficial veins running just under the skin, largely independent of the arteries. And then you have deep veins, which closely accompany all the major arteries and share their names.
And valves are important.
Critically important. Both systems have valves to prevent blood from flowing backwards due to gravity. But the deep veins, which handle the majority of the blood return from the muscles, are much more numerous and have more valves than the superficial system. The contraction of the surrounding muscles, the calf pump, and even the small foot muscles is essential for squeezing blood up through these valved deep veins.
And lymphatic drainage. You mentioned an asymmetry here.
Yes, this is a really vital clinical point to remember. Lymph fluid drainage from the lateral side of the foot and the lateral aspect of the leg generally follows the path of the small saphenous vein and drains first into the popliteal lymph nodes located behind the knee.
Lateral foot drains behind the knee first.
Okay, but drainage from the medial side of the foot and the medial leg, following the great saphenous vein, largely bypasses the popliteal nodes altogether. It travels straight up and drains directly into the superficial inguinal lymph nodes in the groin.
So medial foot drains straight to the groin.
Correct. This means if you see signs of infection on the foot redness, swelling, knowing whether it started medially or laterally, it tells you immediately which set of lymph nodes to palpate first for enlargement or tenderness. Lateral infection, check behind the knee. Medial infection, check the groin.
All right, we've covered the muscles, nerves, and vessels. Let's move on to the framework itself, the joints that allow all this machinery to produce movement. We're looking at pages 1254 through 1259 now, starting approximately with the ankle joint proper, the talocrural joint, designed for power and stability.
Absolutely. The talocrural joint is often described as a classic hinge joint, like the hinge on a door. But it's a very stable, well-designed hinge. Its stability comes from the bony architecture.
Mortise.
Exactly. The superior part is formed by the inferior surface of the tibia, the shin bone, and the two projections coming down on either side. The medial malleolus from the tibia and the lateral malleolus from the fibula. Together, these form a deep socket, the malleolar mortise.
Yeah, what fits into that socket?
The dome-shaped upper surface of the talus bone, called the trochlea of the talus. This mortise grips the talar trochlea very securely, especially in certain positions.
So being a hinge, its main movements are?
Pretty much restricted to movement in one plane: dorsiflexion, pulling the foot upwards towards the shin, and plantar flexion, pointing the foot downwards. The total range is typically around 70 degrees or so between those two extremes.
But the stability isn't constant throughout that range, is it? Page 1265 mentions a key difference.
That's right. The stability changes depending on the position. The joint is most stable in full dorsiflexion.
Why then?
Because the trochlea of the talus isn't perfectly cylindrical, it's wider at the front than at the back. When you dorsiflex, that wider anterior part wedges tightly into the malleolar mortise, locking the joint. Very little side-to-side wiggle room.
Okay, and conversely?
Conversely, the joint is least stable in full plantar flexion. When you point your toes down, the narrower posterior part of the talus is sitting within the mortise.
Giving some slack.
Exactly. This allows for a small amount of wobble, a little bit of side-to-side movement, some inversion and eversion that isn't possible when you're fully dorsiflexed. And this inherent instability in plantar flexion is precisely why most ankle sprains happen in that position.
Ah, that makes sense. So let's talk about the ligaments that try to prevent excessive wobble. There's a big difference in strength between the medial and lateral sides, isn't there?
A huge difference. On the medial side, protecting against excessive eversion, the sole turning outwards, we have the incredibly strong medial ligament, often called the deltoid ligament because of its triangular shape.
Deltoid. Strong.
Very strong. It's a thick, fan-shaped band with multiple parts attaching the medial malleolus to the talus, calcaneus, and navicular bones. It provides massive stability to the medial ankle. Injuries to the deltoid ligament are relatively uncommon because it's just so robust. It often takes a fracture of the fibula to allow enough force to tear it.
Okay, but the lateral side is a different story.
Completely different. The lateral ligaments, which resist excessive inversion, the sole turning inwards, are structurally distinct and much weaker. There are typically three main components forming the lateral-collateral ligament complex.
And one of these is notorious.
Extremely notorious. It's the anterior talofibular ligament, or ATFL. It runs from the lateral malleolus forward to the neck of the talus. The source specifically points out that the ATFL is the most frequently injured ligament in the entire human body.
Wow. The single most frequently injured ligament. That's quite a statistic.
It really highlights the vulnerability, and it goes back to that instability in plantar flexion.
So what's the typical injury mechanism?
It's the classic ankle sprain scenario. Someone inadvertently, often suddenly, inverts their foot while it's plantar flexed and bearing weight.
Like landing awkwardly from a jump or stepping off a curb wrong?
Exactly. That combination, plantar flexion, where the joint is least stable, plus forced inversion, stretching the lateral side, under body weight, puts an immediate massive tensile strain directly onto that relatively weak ATFL, and it often tears, partially or completely.
Makes perfect sense why it's so common.
Yeah.
Okay, moving down from the main ankle joint, the foot itself has many joints between the tarsal bones. These allow for adapting to uneven surfaces, right?
Yes, the intertarsal joints are crucial for that adaptability. While the talocrural joint handles the up and down hinge motion, the joints just below it are responsible for the side-to-side tilting and twisting. The two most important ones, functionally, are the subtalar joint, also called the talocalcaneal joint between the talus and calcaneus, and the transverse tarsal joint.
Transverse tarsal is that one joint.
It's more of a functional complex. It combines the articulations between the talus and navicular medially and the calcaneus and cuboid laterally. These two joints, the subtalar and the transverse tarsal, work together very closely.
And their main job is?
Their primary function, working synergistically, is to produce and control the complex multiplanar movements of inversion and eversion of the foot.
The movements that turn the sole inwards or outwards.
Precisely. Inversion lifts the medial border of the foot, turning the sole inwards. Eversion lifts the lateral border, turning the sole outwards. These movements are essential for walking on uneven ground, allowing the foot to conform to the surface while the leg stays relatively vertical.
The source also mentions that flexion of the toes, especially the big toe and second toe, augments these movements. How does that work?
It speaks to the integrated nature of the foot. When you strongly invert or evert your foot, especially against resistance, you'll often find yourself instinctively flexing or adjusting your toes as well. This fine-tuning by the intrinsic muscles helps to maximize ground contact, enhance stability in that tilted position, and prepare the foot to act either as a rigid lever for push-off or a flexible shock absorber upon landing, depending on what's needed next. It's all connected.
So we have the bones providing the structure, the joints allowing movement, and the muscles driving it. But holding the whole bony framework together, especially under load, requires strong ligaments, particularly for maintaining the arches. We're looking around pages 1261 to 1264 now. The arches are like the foot's suspension system, right?
Absolutely, especially the longitudinal arch, running from heel to toes. It's not rigid. It's designed to deform slightly under load to absorb shock and then spring back. Without constant, powerful support, though, that arch would just collapse flat under our body weight.
And that support comes from multiple sources.
Yes, it's a combination. The shape of the bones themselves contributes somewhat. The pull of extrinsic muscle tendons running under the foot provides dynamic support. But the primary passive support, the structures that resist stretching under sustained load, comes from incredibly strong intrinsic ligaments on the plantar side.
Which ligament is considered the most critical for passively supporting that main longitudinal arch?
That would have to be the plantar calcaneonavicular ligament. It's much better known by its nickname, the spring ligament.
The spring ligament. Why is it so crucial?
Its location and function are key. It spans the gap on the medial side between a part of the calcaneus called the sustentaculum tali, which supports the talus, and the navicular bone further forward. Critically, it lies directly underneath and supports the head of the talus.
And the talus head is where all the body weight comes down from the leg.
Precisely. The talus is the link between the leg and the foot, and its head is the highest point, the superior, most weight-bearing element of the longitudinal arch. The source actually refers to the spring ligament as supporting the keystone of the arch.
The keystone, like in a stone archway. If it fails.
If the spring ligament becomes stretched or torn, maybe through chronic strain or acute injury, the head of the talus drops downwards immediately. The keystone effectively falls out of place. This leads to the collapse of the medial longitudinal arch, resulting in the condition commonly known as pes planus or acquired flat foot. So this ligament is the primary passive defense against that collapse.
Wow. Okay, another major ligament mentioned is the long plantar ligament. What's its role in this system?
The long plantar ligament is another massive reinforcing structure, this one located more laterally but still centrally. It runs from the plantar surface of the calcaneus forwards to the cuboid bone. It's the longest of the tarsal ligaments.
Does it just connect those two bones?
Primarily, yes, providing strong support to the lateral aspect of the longitudinal arch. But its architecture is quite clever. Some of its deeper fibers actually extend even further forward beyond the cuboid, attaching to the bases of the second, third, and fourth metatarsal bones.
Why extend that far forward? What does that achieve?
By bridging over the groove on the cuboid bone and reaching the metatarsal bases, these fibers form a kind of roof, creating a fibro-osseous tunnel. And running through this tunnel is the tendon of a very important extrinsic muscle, the fibularis longus, or peroneus longus.
Ah, so the ligament guides that tendon across the sole.
Exactly. The long plantar ligament therefore does two jobs. It provides strong passive support to the lateral longitudinal arch, and it creates a pathway that harnesses the powerful dynamic pull of the fibularis longus tendon, integrating it directly into the arch support mechanism. Fibularis longus is crucial for supporting both the longitudinal and transverse arches.
That's fascinating. This intricate layering of support, the bone shapes, the deep fascia like the aponeurosis, these incredibly robust ligaments like the spring and long plantar, and then the dynamic pull of muscles. It really paints a picture of the foot as this finely tuned machine built to withstand incredible forces. The integration of passive and active support is just masterful.
It truly is. Every component plays a role in allowing us to stand, walk, and run efficiently and safely.
Okay, let's bring all this detailed anatomy back into the clinical world. Thinking about injuries, common problems, and how we assess the foot, we're drawing from pages 1218 to 1225, plus the summaries on 1265 and 1266. Starting with fractures, the metatarsals seem quite vulnerable.
They are, definitely. Metatarsal fractures tend to happen in a couple of main ways. You can get fractures from direct trauma. Someone drops a heavy weight right onto the top of their foot. That often causes comminuted fractures, multiple pieces.
Ouch.
Yeah. Or, perhaps more commonly in athletes or people starting intense training, you see fatigue fractures or stress fractures.
Other use.
From repetitive cumulative stress. Think of soldiers on long marches or runners increasing their mileage too quickly. The bone doesn't break from one single impact, but micro-damage accumulates faster than the bone can repair itself, eventually leading to a complete, often transverse fracture line. The second and third metatarsals are common sites.
The source also mentions a very specific type linked to ballet, the dancer's fracture.
Yes, the dancer's fracture is a fascinating example of how extreme biomechanics can cause injury. It's particularly noted in female ballet dancers who use the demi-point technique, balancing on the balls of the feet. It apparently often happens not during a jump or landing, but from a loss of balance while on demi-point.
So the full weight comes down wrongly.
Exactly. The entire body weight gets suddenly and eccentrically loaded onto one or perhaps two metatarsals, usually the second or third, causing it to fracture. It really shows the limits of the structure when subjected to these highly focused, potentially unnatural forces.
And sticking with sports injuries, there's a very common fracture involving the fifth metatarsal. The mechanism sounds familiar.
It should. It's the avulsion fracture of the tuberosity of the fifth metatarsal, sometimes loosely called a Jones fracture, although a true Jones fracture is slightly different, more distal in the shaft. This avulsion fracture is extremely common in sports, involving quick changes of direction or jumping basketball, tennis, soccer.
And the mechanism is like the ankle sprain?
Precisely like the severe inversion ankle sprain, the foot is suddenly and violently inverted. Remember the fibularis brevis muscle tendon? It runs down the lateral side and attaches very strongly onto that prominent bump on the base of the fifth metatarsal, the tuberosity. When the foot is violently inverted, that tendon pulls so hard in the opposite direction that instead of the ligament, like the ATFL tearing, the tendon actually rips its bony attachment point right off the shaft of the metatarsal. It avulses the tuberosity. Same forceful inversion, different structure fails, sometimes the ligament, sometimes the bone.
Understanding the anatomy explains the injury patterns perfectly. Now, to assess these injuries, or just check the foot's general state, palpation is key. What are the essential surface landmarks we should be able to find based on page 1218?
Well, starting simply, you should always palpate the malleoli, the ankle bones. And if you feel your own ankle, you'll notice a distinct difference. The tip of the lateral malleolus on the outside from the fibula extends noticeably farther down, more distally, and also sits slightly more posterior than the medial malleolus on the inside from the tibia.
That asymmetry is normal.
Completely normal and important. It contributes to the stability of the ankle mortise and dictates the oblique axis around which dorsi and plantar flexion occur.
Okay. And moving on to the top of the foot, the dorsum, which tendons are crucial to identify for assessing motor function.
Two main ones are easily palpable. First, the tendon of the tibialis anterior, TA. You can find it easily just lateral to the sharp anterior border of your tibia, the shin bone. Trace it down. It runs slightly medially towards the inner side of the foot. It's the primary dorsiflexor of the ankle.
Okay, TA tendon.
Then ask someone or do it yourself to actively lift their big toe upwards, dorsiflex the hallux, just lateral to the TA tendon. Another prominent tendon will pop right up. That's the tendon of the extensor hallucis longus, EHL.
EHL, lateral to TA.
Right. Knowing where these two are is helpful not only for checking their function, and thus the deep fibular nerve, but also because the dorsalis pedis artery pulse is typically found in the little valley between them or just lateral to the EHL tendon.
Very practical. Okay, we've covered an immense amount of detail today. From the intricate 4 layers of intrinsic muscles, each with its role, through the specific nerve territories and blood supply routes, the critical ankle ligaments, especially that weak ATFL, and the vital ligaments supporting the arches, like the spring ligament. To wrap it all up, let's revisit the core organizing principles. The bottom line for the foot, as the book puts it on page 1266.
Yeah, the source really boils it down to 3 fundamental takeaways. First, the basic structural organization. You have to remember, the intrinsic muscles live in 4 distinct layers, and these layers are contained within 4 fascial compartments. This layered and compartmentalized structure is key to how the foot manages pressure and function.
Structure is layers and compartments.
Okay.
Got it.
Second is the importance of the non-contractile protective structures, specifically the plantar aponeurosis. It's not just passive tissue, its density, working with that specialized fat padding, provides absolutely essential protection for the underlying nerves and vessels, shielding them from the crushing forces of weight bearing. It also passively supports the arch.
Protection via aponeurosis and fat. And the third key takeaway.
It's about the overall functional mandate of all those intrinsic muscles we detailed. They function primarily as a group. Their main job is collective maintenance of the longitudinal arch and providing stability. Function follows form. They prioritize structural integrity over the kind of fine individual dexterity we see in the hand.
Function is group stability for the arch.
Exactly. And as a final point related to motion, remember that axis difference. Unlike the hand's third digit axis in the foot, the second digit serves as the fixed central axis for all abduction and adduction movements, again, reflecting the foot's primary role as a stable weight-bearing foundation. #tag outro.
Well, we have definitely completed a deep dive into the foot. It might just be the most elegantly complex structure in the entire lower limb, wouldn't you say?
I think you could easily argue that. The way it balances strength, flexibility, and sensitivity is remarkable.
We've mapped its protective fascial layers and compartments, explored all 4 layers of intrinsic muscles from those big abductors down to the tiny lumbricals and interossae doing their specialized jobs. We detailed the very specific nerve territories, the crucial blood supply arches, and analyzed the key joints, the powerful but potentially vulnerable talocrural joint, and those essential intertarsal joints giving us inversion and eversion for uneven ground.
Yeah, really understanding the foot's anatomy unlocks so much about how we move. It's this incredible structure that has to absorb impact, adapt to surfaces, and then instantly become a rigid lever for propelling us forward, over and over again.
Having mastered this complex distal end, we're now set to move proximally up the limb. Our next deep dive will tackle the remaining major joints: the incredibly strong and stable hip joint, the large, complex, and often problematic knee joint, and the supporting tibiofibular joints.
Sounds good. Looking forward to connecting the whole kinetic chain, from the hip down to the toes we just covered.
So, reflecting on the foot's intricate design, maybe a final thought for you to consider. Given the constant battle between stability and mobility, arch height or ligament laxity cascade upwards, potentially influencing knee or even hip mechanics over time. Something to ponder.
An excellent point. The foot is the foundation, and issues there rarely stay isolated.
Thanks for listening to Bookfulness.